So I think without further ado, we'll move over to Professor Bryn Lloyd Evans, who's going to talk about our national survey that we had conducted following the systematic review.
Hi, everybody. Can you see my slide okay there?
Yeah.
That's fine. Thanks, Bryn.
Brilliant. Good. Okay, so hi. So I'm Bryn Lloyd Evans. Like Dora, I work at University College London, and I'm one of the research team who worked with Liz throughout the MEMOS study. And nice to be here today. So at the sort of first stage of MEMOS, as well as reviewing what we could learn from the published papers about SARCs, we wanted to get an overall picture of how SARC services in England, which was the focus of our project, how they were operating. So how services were structured and what types of support they were providing for people with relation to mental health and substance use needs. So the way we tried to do that was with an online survey, an online questionnaire for SARC managers. And this was a bit of the study where we joined forces with the other SARC study that NIHR were funding. So this was the MESARC study led by Laura Doherty from Coventry University. And their focus was more generally about how SARCs were operating rather than our specific mental health focus. But it was definitely helpful to join forces for this survey. So it meant we were kind of chasing busy SARC service managers just once for one questionnaire rather than twice for two different ones. But perhaps one limitation for us was it meant that we had to be quite economical with how many questions we could put in about mental health and substance misuse, because we were just one bit of a bigger survey. So we distributed it online, and in 2019, we did this survey, and it was really only open quite briefly for 6 weeks, but we did quite a bit of assertively asking people if they could help at that point. So really what we tried to look at was the sort of things that Dora's been talking about in the review. So really, how did SARCs, what are the structures that they've got for trying to identify people's needs with mental health or substance misuse, and then what types of support can be provided both in-house, and what are the kind of mechanisms for linking people in with other services locally. And we were pretty pleased in this fairly rapid survey to get a decent response rate. So just over 3/4 of SARC managers found time to complete our survey, and big thank you to them. So 77% response rate out of the 47 SARCs in England. Although we should sort of point out that not all respondents answered every question in our survey. So we've got slightly lower response rates for some questions. So I'm going to talk you through just some headlines of what we found now. Apologies, some of these slides have graphs on them with very small writing, but I'll sort of try and talk around what the main findings were. So the first thing we asked about was staff, the staff teams in SARCs, and how many of the staff had mental health qualifications or backgrounds or training. And the short answer was a fairly small proportion of staff. So just over 20% of staff in SARCs had mental health training or qualifications. So typically in a SARC staff team, you might have 1 or 2 members of the team who have got some mental health sort of specialist expertise, but certainly not the whole team typically. And then we asked about how do SARCs actually try and identify needs for mental health support or substance use support for people coming to the SARC. And we asked particularly about, do they use any structured tools or assessment methods to try and identify people who might need support? And rather like the findings of Dora's review, this was not common. So we found only 38% of SARCs used any tools at all, but that figure probably sounds better than actually the reality, because that's just any tool for any condition. So for any specific thing, it was less than that. So the proportion of SARCs who might screen for PTSD or for drug and alcohol use was lower than 38%. So instead of that, most services relied on staff's kind of just judgment and their resources to spot people who might have needs for mental health or substance misuse support. And you can see that that's potentially problematic if most SARC staff don't have mental health training, and yet they're having to rely on their own resources and judgment and skills to try and identify when people might need help in the first place with mental health concerns. So then we tried to ask about what types of support are provided in-house by SARCs, either by the SARC themselves or at a sort of by another service, but at the same place. And the original model of SARCs in England was that they'd be a sort of one-stop shop who could provide support for everybody's needs following a sexual assault, rather than people needing to access lots of different services. But again, as you can see here, it's a pretty patchy picture. So just over half of services had a counselling service that was either within the SARC itself or co-located with it, and rather fewer for other types of mental health support as well. So referral pathways for support beyond SARCs are also important, obviously important if the SARC itself doesn't provide any in-house support. But even where SARCs do, there'll be people whose needs for support are greater than the SARC can sustain. And so having kind of clear pathways to get people help from other mental health services locally feels really important. So we asked about, did services have service level agreements, referral pathways, so that they could just link people into care quickly and easily? And again, you can see here it's a fairly patchy picture. So just under half of teams had any kind of clear pathway agreed with mental health crisis services, with community mental health teams, and rather less than that with substance misuse services and primary care counselling as well. And this wasn't a kind of neat divide either. So it wasn't that half the SARCs had good in-house support and the other half had good referral pathways onto other services. Some SARCs did both of those and some SARCs did none. So the next thing we did with this data that we collected was try to look if we could find patterns in it and see sort of groups of service provision. So one model of SARCs who do it this way and another that do it another way. And we used a statistical process called cluster analysis to try and look at the data and see if we could see how best it groups together. So cluster analysis is a pretty dark art in the best of times, really, that quite often you might get a sort of statistical grouping of services that may or may not make any real world clinical sense when you look at how they've come out in the analysis. And it's particularly challenging when you've got quite small numbers of respondents and not many variables. But we were actually quite pleased that we did get a sort of result of this that kind of made some sense to us in the team and when we consulted people who work in and with SARCs. And that SARCs could sort of be grouped into three types. So if you look at this, again, apologies for the small text in this table, but type 2, which we called the kind of clinicians and pathways groups, these were services who were likely to have some staff with mental health training. They were least likely to provide in-house support, but they were most likely to have sort of pathways to refer on to other services. So they were very much a kind of screen and identify need and then refer people on, rather than try and meet mental health needs within the SARC. Type 1 was did a bit more. They were a bit more likely to provide counselling in-house, but not so likely to have good referral pathways onto mental health services. And type 3, what we called the integrated and holistic care group, were the SARCs who were most likely to provide a range of support for mental health and substance misuse needs. So they were most likely to provide in-house counselling and support to try and address drug and alcohol needs and to have written referral pathways onto services. And I think you can see that if you're coming to a SARC and you've got mental health needs that to be met, that there could be quite a difference to your experience if what you get is kind of screening and then referral on somewhere else versus being provided with support by the SARC. So really a question for the rest of the study is just what works best for whom in what circumstances and what's people's experience that they like. So a couple of limitations to acknowledge. We got a decent response rate, but we didn't get responses from all the SARCs, so we've missed a few services. We got one response from the service manager or their delegated respondent, and I guess there's a bit of pressure on managers to give the rose-tinted view of how things should work ideally, so it's possible we've got a slightly rosy picture. This survey was only conducted a few years ago, but pre-COVID is another world, isn't it? Service provision has obviously moved on, so this is a slightly historical snapshot now of SARCs. We shouldn't try and oversell our cluster analysis. It was a pretty small exploratory look at SARCs, but I think it was useful. Both it kind of really reinforced what Faye was saying at the beginning, that there's a lot of variation in how services are organised and what types of support they provide. And it also kind of informed our choice of services to work within the rest of the MIMOS study. So we were quite keen to get at services that represented all of these three clusters. So we're not just looking at one type of SARC, but we're getting the range of service provision. So that's kind of what we did. So really quick summary, in the survey we found that SARC services on the whole are using fairly low levels of use of standardized screening tools to identify mental health or substance use needs. They're relying on staff to use their own judgment, and yet there's fairly low levels of mental health expertise and training within the SARC staff team. So that's potentially a challenge. There's relatively low levels of co-location of mental health and substance misuse support on site in SARCs, and yet there's also patchy provision of referral pathways on to key mental health and substance use services in the community. So that's another challenge. And really the rest of the study, a big question was how do SARCs best navigate these challenges and provide things that help provide good quality care that's acceptable and helpful for people using the services. So that's it from me. I'll stop sharing and thank you.